partly determined by genetic factors. That's actually new. No one has ever looked at the biology of resilience in this way before. No one has ever looked at whether it's heritable, whether it runs in families. That's actually quite an interesting finding. And actually what we find is that about 8% of the sample meet the criteria for a probable anxiety disorder. It's, as expected, slightly higher in boys than in girls. Girls tend to have more anxiety disorders than boys. It's actually significantly lower than that's seen in the United States. The prevalence of anxiety disorders in kids is 20 to 30% in the United States. And the question is that due to lower rates of anxiety in Costa Rica? And if so, what are those factors, and can we bottle them and sell them? Or decreased sensitivity of the screen. Is the mask not a great instrument here in Costa Rica? Is the cutoff wrong? So we don't know yet whether there really is less anxiety here, or whether we're just not picking it up. That's one of the things we'll be able to answer with this study. So then we looked at the relationship between resilience and the presence of psychopathology. And we used the presence or absence of an anxiety disorder as determined by this scale as the outcome. We controlled for gender and age, because the older you are, the more likely you are to have an anxiety disorder. And if you're a girl, you're more likely to have an anxiety disorder. So we wanted to take that out of the equation and just look at how do you relate resilience to psychopathology. And what we found was, for every point increase on the temperament scale, you had a 12% increased risk of having anxiety disorder. So the more anxious personality you had, the more likely you are actually to develop an anxiety disorder that's clinically significant. Interestingly, the risk for an anxiety disorder decreased by 11% for every point increase on the resilience scale. So for every point more resilient you are, you're 11% less likely to have an anxiety disorder. So these two things essentially balanced each other out. We don't have data to look at what the interaction between these two things is, which is the thing I'm the most interested in, because we don't have a big enough sample. But clearly, our hypothesis is holding true, which is that resilience really is protective, at least in this very small early sample. So I'm going to conclude here very quickly, actually. The conclusions are that childhood anxiety is common, but it's often unrecognized. And we found that to be the case in our studies in Costa Rica as well as in the United States. It's a risk for the development of later clinically significant and impairing psychiatric illnesses. We can actually effectively screen for school children, for anxiety in school-age children using these very quick instruments. They take 15 minutes to administer, maybe, something like that. And we can also screen for potential protective factors. Once the individual risks and protective factors are identified, then we can actually develop programs for early identification, potentially prevention of anxiety disorders, and for those kids who actually have already passed the threshold and are ill, treatment. So it's really, the point is to develop intervention programs at the school level, ultimately. I think I will stop there and take questions. Thank you.
Why do you think that kids in Costa Rica are presenting a lower percentage of anxiety than in the United States? Let's say that it's not a measurement flaw, it's just standard in every place. Well, what are your thoughts for you about that?
That's actually a great question. And the disclaimer here is this is just my wild idea. There's no data. I actually do think that the rates of anxiety disorders are lower here in Costa Rica. We have done genetic studies in Costa Rica for many years of Tourette syndrome, obsessive compulsive disorder, attention deficit hyperactivity disorder, and actually bipolar disorder as well, although I'm less involved in those studies than I was. And we find consistently across those studies, with some exception in the deficit attention studies, that kids who have those disorders have the same number of symptoms as the kids that we have in the United States, but they're much less severe and they're much less impairing, and they're much less likely to have co-occurring depression, generalized anxiety disorder, so they're cleaner. They have TOC, but not all of the other things that go with TOC. So it seems fairly clear to me that there is a reduced risk here in Costa Rica for these disorders. There are three major possibilities. One is that the genetics may be different, right? You may have an inherited decreased risk, maybe. The other, though, is that there's some cultural factors or socio-demographic factors. There's a study in Puerto Rico looking at the prevalence of childhood psychiatric disorders that showed that, let's take OCD, TOC, for example. The rate of OCD was higher in urban settings than it was in rural settings. And it's quite possible that the same is true for other anxiety disorders. Costa Rica is primarily an agrarian setting. San Jose, okay, is a big city, but much of Costa Rica is not San Jose, and it may be that rural settings or agrarian settings actually are less stressful and predisposed than, in the same genetic risk, are less likely to cause disorders. Whether that's true or not, we have not been able to sort out, but the Puerto Rico study does suggest in the same cultural environment, in the same genetic risk environment, that socio-demographic factors are important in increasing or decreasing the risk. So those are two possibilities. There are also obviously many others, but I think probably what we'll find is that symptoms here are accommodated and tolerated, which may decrease the risk for stress and other co-occurring conditions, and also that just the general lifestyle may be a little easier. But that's a wild guess, so don't quote me on that.
And I was just wondering, you're not testing the parents in the study, right? And it would be interesting because, like, to see what happens when one of the parents has high resilience and one has low resilience, like it happens in a family, I know. And to see which one prevails in the children.
It would. We are not actually testing the parents in this study because it's a big study to test 5,000 kids. But we would like to do that ultimately, and what I would predict is that because the traits are quantitative, they're distributed normally like intelligence or blood pressure, is that what you would get in the child is what you get for height, for example. That the child is intermediate between the parents' heights. If you have one very short parent and a very tall parent, and you adjust for gender, the kid ends up somewhere in between. Probably what you would get is something like that, but I don't know. We do ask about family history of illness, but we don't ask about resilience because there's not an easy way to do that without testing the parents.
We know specifically if the parents have anxiety or depression.
We do specifically, Anna's pointing out, we do specifically ask if the parents have a known history of anxiety or depression. So we ask for family history.
Entonces a los niños que tenían, que eran muy resistentes, se les llamaba niños dientes de león. Ese era un término que se usaba cuando todavía no hablábamos de resiliencia aplicada a la salud mental, o aplicada, solamente se usaba el término aplicado a la física, como explicó la doctora Ordóñez. Entonces, ese es un tema interesante, vamos a volver sobre eso, sobre los dientes de león. Entonces, esto lo pueden leer ustedes, pero es una historia breve, parece muy larga, pero es una historia breve. Está copiada textualmente de la persona que lo escribió. Dice: mi vida ha sido una serie de accidentes y encuentros fortuitos. Yo era el segundo hijo de una familia de inmigrantes. Siendo zurdo y disléxico, en la escuela venía detrás de mí mi hermana, quien era excepcionalmente talentosa, mientras yo apenas podía pasar. No podía leer bien y me pegaban por usar la mano izquierda. Súbitamente, las personas alrededor mío empezaron a enfermarse y a morir. Primero mi abuela cuando tenía 6 años, luego mi madre cuando tenía 8 años y mi tío favorito cuando tenía 13 años. A los 18, mi única tía se mudó fuera de la casa y mi padre murió. De pronto, estaba sin familia y sin casa. Me fui a la universidad y estudié ingeniería eléctrica, y a los 2 años escuché una charla de un sociólogo famoso y me interesé en la demografía. Me gradué y sin saber qué hacer, empecé a trabajar en la escuela de psicología. Me interesé en la psicología fisiológica y luego en los trastornos del desarrollo. Estos son fragmentos de una vida bien vivida, una vida de accidentes y encuentros azarosos. Cuando se ve así vivida parece una secuencia de brincos y saltos más que una progresión ordenada. Y mientras trataba de entender el desarrollo humano, trataba de buscar un sentido a mi historia y así fui construyendo una identidad y una narrativa, una historia de mí mismo. Esta necesidad de una historia personal me llevó y aún me lleva a construir un inicio, un intermedio y un final. Michael Lewis es un extraordinario psicólogo del desarrollo que ha hecho aportes muy importantes a la psicología.